So I'll move down to femoral neck fractures, and I was asked to provide an example of a young and an example of an old case, and those are relative terms. And for femoral neck fractures, 50 seems to be the cutoff, and I think that's just because you don't really plan to do an arthroplasty in someone younger than 50, and the longevity of reproducibility of arthroplasty is good enough that 50 has kind of become the cutoff, for a displaced femoral neck fracture. So first we'll start with a younger one, and this patient actually was right at 50. But kind of fell into this group where he was treated with fixation. So kind of a down and out guy, frequents homeless shelters, was homeless, and was standing on a chair with wheels trying to fix an exit sign. He had a history of substance abuse and may or may not have been under the influence while he was doing that, but fell off this chair and had left hip pain. And you can clearly see the femoral neck fracture on the left. And I think this gets into an interesting discussion about how you assess these injuries. So this is more of an AP of the proximal femur and a cross-table lateral of the hip. So when you have a fracture like this in a patient where you're planning to do some sort of fixation because they're in that younger category, I think a good discussion point to begin with is what do you see here? What kind of fracture is this? We're all aware of various classifications for femoral neck fractures, Garden being one, Powell's being another, and what are the important things that you look at to determine what sort of fixation you might proceed with, or arthroplasty if that's a consideration. And I think this is just sort of discussion. So who's ready to make a decision based on those X-rays, and who isn't? And if not, what more information can we get you? What can we do to get more information? Anyone want to comment? If not, ask Joe, Steve, or Kyle too. But these are common injuries that we're all treating. So.
I don't want to move the femur, but I do want to see more information. So I might do 2 day views in a case like this, just to get different perspectives of the
Yeah, so that's a good point. That's probably not classically done for this indication, but yeah, someone like Steve's very used to looking at those X-rays and getting, extracting information from them. So what kind of fracture is this? So if we went by, sort of an anatomic classification first, where in the neck is this? So it's sort of basilar at the bottom. How about up at the top? Yeah, so it's a more vertical fracture. So that's kind of classified by Powell classification. And is it displaced? So Garden classification may be a little more for transcervical fracture, but it is tipped, I think, in a little bit of varus. But I think the key point here is the verticality of it. So I don't have Judet views. And Corey Collins wrote what I think is one of the more interesting papers on this topic, where he pointed out that we have some of the worst results with fixing femoral neck fractures of anything. Yet we often just make decisions based on typically fairly lousy X-rays. And there's a paper that Mo Bandari wrote 2004, so it's 20 years old now, where they did a big meta-analysis of the literature up until that point, and the rate of osteonecrosis and non-unions was almost identical to what Kellogg Speed reported in 1934. So we've basically made no progress in our treatment of femoral neck fractures from the 30s to, the turn of this century. I think the non-union rate was in 30%, osteonecrosis 15 to 20%, and we still see those numbers. So Corey pointed out that, we get a CT scan at the drop of a hat, and this morning we were talking about malleolar fractures and getting CT scans and things, and tibial plateau fractures, acetabular fractures, but we typically don't get them in these fractures. And you have to guess what I'm thinking, like I tell the residents all the time. But what more information do we need? I mean, we can see it's a vertical fracture. But what else do you notice on this X-ray? The femur is externally rotated. So traction X-ray is something that's very simple. Traction internal rotation view. Joe, you're gonna.
Yeah, it was something that came to my attention a few years back is the importance of anterior angulation of the femoral neck. If you have more than 20% of anterior angulation, it's a bad prognostic indicator for outcome.
Yeah.
And unfortunately, yeah, apex anterior to femoral neck. Unfortunately, you can't determine it on that.
Yeah, it's hard to see. Sometimes you can clearly see like a proximal humerus that the head is, tilted forward or back, often posteriorly, but, the apex anterior angulation. So how about the verticality of it? What does that create problems for? Yeah, when you're trying to fix a femoral neck fracture, for example, it doesn't matter if you're dealing with cannulated screws or a compression hip screw, dynamic hip screw, whatever you want to call it. The whole point is it allows compression. So how do you compress across a fracture that's not perpendicular to the, the implant? So that's the big issue, and that's what what Corey brought up in his paper. So here's a CT scan. So you can perhaps better identify the verticality, but then on the axial view that I put there on the right, you can see that angulation of the femoral head a lot more apparent than perhaps it was on the X-rays. You can see whether or not there's comminution, but what Corey points out is you can also try to assess, is the fracture angulated in the coronal plane? So is it purely like you cut a saw, took a saw blade and cut directly across the femoral neck, or was it angulated? Because that's really important for fixation. If you've got much angulation in the coronal plane, any compression is going to result in corresponding shearing. Yeah, there's a little bit there. You're talking about that little fragment, or just on the anterior neck. Yeah, it does. I agree. That's not sure if that's there or not, but so that this fracture is probably more transverse than some of them, which is good. This isn't perhaps a good image to assess that on, but that's what I'm looking at, is how is there a lot of obliquity in the coronal plane, because that's going to really increase the likelihood of fixation failure, and something you might want to consider. And then the vertical nature of the fracture, there's lots of people, the role of plating the femoral neck fracture, trying to buttress that inferior portion, trying to use these screws that are perpendicular to the fracture that compress it better. There's a lot of different fixation techniques that have been described to try to address the biomechanical consequences of this more vertical fracture pattern. So plan is fixation still a good option for this fracture?
I missed it. How old was this patient?
This patient happens to be 50, so 50. So a little on the older side. So I'm supposed to be showing a young femoral neck fracture, but I just came across this case and thought it brought up a lot of these discussion points. But so yeah.
I think it's got more than one fraction.
Yeah, you're talking about the.
Just subcapital, there looks like there's some going across.
Yeah.
And then from the distal fraction towards the.
I think this is a piece here.
Yeah.
Yeah, that fragment too.
What's there? I don't see anything anteriorly.
What about coming across? There's kind of you may not be able to see it from there, but coming across subcapital, it looks like there might be some looseness.
This looks like the old growth plate.
Yeah.
How about just straight up? And
I don't see anything.
there.
He's looking at a line that kind of comes straight down, like where that bottom piece kind of has a little bit of a gap. I see what you're saying, but I don't think it's real.
Yeah, I see it too now. I actually didn't really notice that either going through the images. So they would have fixed this guy. Yeah. So here's some So we actually have a protocol at our place where we try to get traction, internal rotation views in every hip fracture. The New York group, Ken Eagle and his group did a study that was reported in a hospital special joint surgery or something journal. It wasn't widely recognized, though he spoke on it. But when you do this traction internal rotation view, what they did is they had surgeons look at the injury films and try to classify the fracture and make a decision on treatment. And then they did the traction internal rotation view and repeated the questions. And a lot of times your assessment of the fracture changes it could be from a transcervical to a basicervical, from a basicervical to an intertroch. You might recommend fixation to an arthroplasty. I mean, there were a lot of significant information in this X-ray. So it also shows you how well the fracture reduces too, which is nice to know before you go to the OR. So this is a simple. This happened to be an intraoperative traction view. They didn't do it in the ER, but now we actually try to do it in the ER. But here's the person on the fracture table in surgery. That's just a guide pin that was, I think, kind of being used to mark out where the incision. The surgeon wanted to make the incision, but with traction, you can see this fracture reduces really, really fairly well. And it's interesting on the lateral view, the fracture line looks a lot more oblique than I thought it did on the CT view. Anyway, these are intraoperative views. So this is the fixation, sort of a higher angle hip screw with a derotation screw. As is often the case, the reduction looked a little better here than it did after the implant was in. It lost a little bit of fixation on just above the calicar, above the lesser troch there.
Yeah, what I've experienced with putting in a DHS or an SHS in younger bone, you can, since these screws are non-self-tapping, you can actually spin that head and disrupt your reduction.
Yeah, there's the interesting papers about right versus left and the way, the screw is always tightened with clockwise rotation, but, there's a difference. In one side you're helping reduce it, and the other side you're trying to mal-reduce it.
Even with the guide wire for the 2.8 guide wire for the 7.3 cannula screw, I still managed to bend that guide wire.
Yeah.
Do you tap these in younger patients?
Yeah, usually. This guy, I think his bone density wasn't as good, and we didn't, but yeah, and in a 25, 30-year-old or something, we often do. Just grip.
Are you happy with your tip to apex distance?
That doesn't look so perfect either.
It's hard to do that though when you're putting
The derotation screw in, yeah.
So I don't have any problem. I'm not saying it's not important, but it's, when you gotta put the derotation, a lot of times I'll put two above it. But yeah, you start getting into problems. And if you also, anyway, you're also trying to use a young glue anteriorly, you really get screw problems.
You all know what the tip apex distance refers to? I think that's well known now. Just the tip of the lag screw to the sort of apex of the north pole of the femoral head. And you measure on the AP and lateral, and it's just some up to less than 25 degrees. And it's been interesting how that's concept's applied to the cephalomedullary nails. But anyway, so I didn't think to measure it for this presentation, but it's probably close to 25. Anyway, happily, this patient did pretty well. This was the last X-ray in the chart, which was just taken at 3 months. But the person had lots of visits elsewhere in the system, and I found this is 2 months. So yeah, this is the immediate post-op view. This is a 2-month X-ray. But it looks about the same. But this patient had kind of a serendipity CT scan where for kidney stones came into the ER and they did a CT scan at 4 months and it looks like it's healed. And then the patient hasn't come back. So I think it turned out okay. But I thought this is just a good illustration of the decision making for imaging and thinking about the implants that you choose.
You were able to get it into valgus.
Yeah, that's some of my senior partners really. Tom Vrecka, Dick Kyle have always kind of emphasized. Dick Kyle was always about the sliding. This is back in the day when, because now I think we have almost the opposite concept of too much compression is bad. And if you have a really unstable fracture and it collapses, 20, 25 millimeters, they almost always end up with failed fixation and a total hip. But that was the concept of what these higher angle screws would facilitate compression and sliding. But this just happened to be, the implant that fit the patient's anatomy. You kind of measure it out and pick the angle. It looks good and gives you the position on the femoral head that you want. All right. So this is a older patient, 65-year-old female, and I wanted to kind of highlight some of the decision making that you have in this age group. The fractures may be a little bit different. Bone density is different. Arthroplasty is a better option, but and of course a lot of these patients in the elderly group are very frail. But this person was diabetic, but took very good care of herself. She used an insulin pump. She maintained her hemoglobin A1C well under 7 and pretty close to 6. She claimed to walk 3 to 5 miles a couple times a week. She just fell from a step ladder and had this fracture. So you can see the injury on the right femoral neck looks fairly impacted. Try to get a lateral to see if there's any of that posterior tilt, like Joe was talking about. Hard to tell.
Yeah, it's hard to tell.
So kind of the same discussion. Can you make a decision on these images or not? So CT scan does show a little bit better that there is a significant amount of posterior tilt. So what do you think about reducing that? You know, with presumably some traction, rotation, the Ledbetter maneuvers, whatever it's called, on a fracture table, and going ahead and using multiple cantilevered screw or a DHS for fixation?
Yeah, I think her hip joint still looks pretty good. She's active. She's got diabetes, a smaller operation, an opportunity to save her own equipment. I think it's worth a try.
Yeah. So that's what we did for much of my career. We went in a different direction with this person, but yeah. So I chose this because there's sort of a, you know, valgus impacted, although this is more posterior impacted. But these sort of impacted femoral neck fractures, we tended to save them and, you know, reduce them to the degree you could. We would never do open reductions typically on these sort of stable fractures because they're usually, you could get a reasonable closed reduction, and we'd fix them with screws. And I saw a lot of patients in my practice where they'd be valgus impacted. We'd reduce the posterior impaction. We wouldn't worry about a little residual valgus impaction, and we'd put the screws in. And they would seemingly heal and do okay for a year or two, and then suddenly they'd come in with hip pain, and everything would have just fallen apart, you know, well after I thought they were healed. And I saw enough of these where it began to concern me, and then I think the literature has begun to show similar experiences with that these so-called impacted fractures don't necessarily do well with screw fixation. And so in my practice, I've become more aggressive at arthroplasty in the appropriate age group, just to avoid, again, those failures and let the patients mobilize. And that's based somewhat on the experience we have with the arthroplasty with the varus displaced fractures. And it depends a lot on the patients. With these, I do elective arthroplasties as well, and we spend so much time trying to optimize these patients and getting their, you know, stop smoking and get their weight down, and get their, if they're diabetic, getting their hemoglobin A1C down under 7, and just, we do all this work. And then we have these trauma patients that are using meth, and they're doing all this crazy stuff, and, you know, their teeth are rotting out, and, you know, we'll sometimes do an arthroplasty in those settings when they're not optimized. And, you know, I'm kind of exaggerating a worst case scenario, but she actually would have been optimized. You know, she really took good care of herself, and so we went on and did you can see a hybrid arthroplasty, which I don't usually do. I usually do unsubmitted stems. That's another discussion, I guess, maybe why I chose this case.
Well, I think the other controversy is, why'd you do a total amount of hemi?
Yeah. So
You're a trauma surgeon.
yeah.
You did a total.
Yeah.
It's frowned upon by the arthroplasty surgeon.
She's 60.
65 and walked 3 to 5 miles. So that's another interesting thing that I've noticed my practice evolve in. So at first it was we basically always do hemi-arthroplasties. And then it's become, you know, well, is the person really active? Are they on their fetal day? Are they still working? You know, are they walking multiple miles? So now it's essentially, do they walk without assistive device? Is kind of my current for doing a total on someone with a femoral neck fracture. You know, so I don't know how other, you know, Kyle or you or others have evolved, but.
I don't have a great scientific answer to this, and I went to a place where I was doing hips on it. I feel very comfortable doing a total hip, but damn, a bipolar so easy, and someone that has kind of a fracture that's related to maybe poor bone, I just decided I didn't want to go through it. And knock on wood, they may come to you, but I haven't had anybody come back and want a total hip afterwards. They've all, you know, get up right away. You know, there's this weird data. It's not weird data, it's data, but I don't understand. There's about a 3 times infection rate with a total hip when they're admitted to the hospital. And, you know, I don't understand it, and I don't get that infection with my, you know, bipolar, unipolar.
Well, I never fully understood why we got rationale is, well, the patient comes in, they have full range of motion of their hip, then they fracture it, and then you put a total hip in, as opposed to an arthritic patient who comes in with a little stiffness. But, yeah, as far as putting a total hip in, a monkey can do it. But there are some increased complications, at least in our hands.
Yeah. Yeah, so this could be the subject of, is the subject of entire days of discussions at courses like this. So every little aspect, do you do anterior, posterior? Do you do dual mobility? Do you, what size front head do you use? Do you cement or uncemented stem? There's so much to this. I do enough elective arthroplasty, and the system I use, it's the same stem either way. It's the same aspect, it's the same broach, it's the same everything. But if I decide to cement, the stem's a little undersized, and I cement. And so I can use a stem that I use all the time and get pretty comfortable with how it should fit and how it should feel, how it should feel, how hard to impact the broaches, all those sort of things. But yeah, in this particular instance, we chose to cement her. So.
What do you think about the position of your cup?
Well, it looks a little. So she probably had a really soft bone, and no, but it's a little bit.
Murray would have loved it. He says there's better range of motion, but.
Yeah. Well, she did fine. That's the fascinating thing. There's those safe zones, and it doesn't seem to matter with dislocation risk anyway.
Do you use an elevated liner or flat neutral liner?
Usually, I almost always use neutral. I try with neutral, and if I can't make it good with neutral, then I actually move the cup around until I'm happy with it.
Yeah, I was trained with an elevated liner, so I put an elevated liner in everybody.
Yeah, I did early in my practice, but they can impinge with those sort of things, and
I've never used an elevated liner.
yeah, I haven't probably in 10 years. Yeah.
It saves you for,
Yeah.
I think it's just a false hope. Oh, yeah,
Yeah.
this is loose, I better have one in.
Yep.
See, I take a different approach. Doesn't hurt it.
It does, maybe impinges.
Yeah.
Well, I've never had an anterior dislocation from a posterior approach.
Yeah, I've never had it.
I've had a posterior dislocation from a posterior approach. All right. What else you got?
That's it.
All right. There you go.
Yeah, although anyone have questions, since we got 5 minutes or so of time that I'm not using? Nope. Okay.